Okay, Dr. Jonathan Wall is a professor at the University of Tennessee. He directs the NIH-funded amyloidosis program that includes imaging and therapies. I promised him that we wouldn't make comments about his kitchen wallpaper, so he wouldn't put up one of those phony backgrounds, okay? So now, direct from the kitchen table where the breakfast dishes have just been cleared away in Knoxville, Tennessee, is Dr. Jonathan Wall to tell us about his imaging study. Dr. Wall?
Thank you, Muriel. Hello. Thank you, Muriel. I appreciate the invitation. And yeah, please do not comment in the chat box about the awful wallpaper. It was not my choice. I appreciate the opportunity to speak to everybody here today. And without further ado, I will share my screen. Okay, so as Muriel said, we're at the University of Tennessee Medical Center in Knoxville, and we've been working for the last many years on an imaging agent for systemic amyloidosis. And in the last 16 months, we've been able to start a clinical trial, and I'm just going to update everybody on how we're doing. So the first thing I'd like to do is thank the patients, or actually do a disclaimer. So although I'll be offering some interpretation of the images here, the data is still very preliminary, and this is a clinical trial, and it's still an experimental procedure. But we are actually performing an interim analysis right now on the first 20 patients, and so I'll be presenting a lot of that data now. The other thing I want to do is thank everybody who's been involved. The patients have been incredible. They've traveled to Knoxville to participate in the trial. And without their involvement, we wouldn't have got where we are. We appreciate them greatly. There are many patients who've signed up to be part of the trial and patients who've contacted us about being part of the trial. And right now, the trial's on hold until the COVID-19 issue is resolved to our satisfaction and everyone can travel. But we look forward to meeting many more of you as you come to Knoxville. So what is AL amyloidosis? This is probably the fourth slide that said this in today's presentation. But I'm going to talk a little bit more in picture form about what happens because it's relevant to the way we're doing the imaging. So you've heard a lot about the plasma cells in the bone marrow that generate immunoglobulin light chains that enter the circulation. And these proteins, for reasons that we don't understand, undergo a misfolding event in the organs or in the circulation, and then they become prone to form amyloid, and small sort of aggregates form, and they'll eventually form a fibril. And as you've heard, these fibrils deposit in organs and tissues and can cause damage, and some of these proteins are also toxic to cardiomyocytes and perhaps other cells in the body as well. So there are two components, two targets for therapeutics in terms for AL amyloidosis. The plasma cell itself that's producing the light chain, and as you just heard from Mike Spector, removing the amyloid that's already in the organs. With respect to imaging, we're extremely excited to be able to image the amyloid deposits that are actually in the tissue. So amyloid is not just fibrils when it's in the tissue. It's composed of many other proteins that come from the blood, such as SAP or SAP, which many of you will have heard of, and is relevant to imaging, and I'll talk a little bit about that. But there are about 30 other different proteins that get pulled into the amyloid deposits from the bloodstream. And the other thing that's contributed to the amyloid, and this is contributed by the cells that are around the fibrils, are sugar molecules known as GAGs. And these GAGs are, as I say, they're sugar molecules, and they're expressed by the cells, and they accumulate in huge amounts in the amyloid deposits themselves. And of course, you have the fibrils. The two things about SAP and the GAGs is that SAP binds every form of amyloid, all the 25 to 30 forms that are known. And GAGs are also components of every amyloid. So they're universal components and universal binding agents. And that's important with respect to the imaging that we're doing in patients. So again, as you've heard from many people, AL amyloidosis is a multi-organ disorder. For that reason, it's very complicated to come up with an accurate, rapid diagnosis. A lot of the symptoms mimic more common disorders. And the other issue is that it's very difficult in an individual to know exactly where the amyloid deposits are in every organ. As Dr. Ruberg mentioned, the heart can be biopsied, and you can look using Congo red staining for the presence of amyloid deposits. But that's one organ. You would then not go through the entire patient and biopsy every organ to get a full picture of where the amyloid is. So you normally only have one organ biopsy if that's absolutely necessary. It's often avoided for safety reasons, and you just have a fat pad biopsy or something like that, which is an indication of systemic amyloid deposits, but it doesn't tell you which organs are involved. So with respect to SAP, serum amyloid P component, or SAP, as I mentioned, binds all forms of amyloid, and it's important in the imaging world when it comes to amyloid, but only in Europe. So SAP is a normal blood protein, and it's isolated from donor plasma in Europe, mostly in the UK at the National Amyloidosis Center. And it's made radioactive with something called iodine-123, and then it's re-injected into patients, and they come back 24 hours after the injection, and they lie on a camera that can pick up radioactivity, and these are the types of images that you can generate. And this is state-of-the-art in Europe right now, and at the National Amyloidosis Center, I think they do about 1,500 to 2,000 SAP scans per year. So this is an example of a patient. This is the front of the patient and the back of the patient. And you can see in this patient, there's some uptake of the SAP in the bone marrow, in the shoulders here. This is probably a little bit of stomach, maybe some activity in the organs, in the liver and the spleen. But mostly this is a bone marrow involvement in this patient. This is an AL patient. This is another AL patient in the middle here. This is the liver uptake, and this is the spleen uptake. So there's amyloid in both those organs, but there's no evidence of bone marrow. And in this third patient, you can see the spleen, the liver, and some bone marrow uptake. And this is the bladder where the patient is going to urinate out the SAP. And this is the thyroid gland. So this is what the state of the art is for imaging amyloid patients in Europe. But as I say, this capability is not available in the US. So we wanted to solve that problem, and that's something we've been working on, as I say, for many years. So what I'm going to describe is our first in-human imaging study at the medical center. One thing to note, that this is not an industry-sponsored trial. This is supported by our gift fund and donations that are made to our program. So this is what we've come up with. This is a peptide, a small protein that we've designated P5+14. Hopefully it'll have a new name soon. And this is what we think it looks like when it binds to amyloid. It forms this helix, looks a little bit like a caterpillar. But what's important about it is these positive charges which line one side of the peptide. And it's that property that allows it to bind specifically with amyloid. There are lots of charges on this peptide, about 12. And so it needs something very negative to interact with. And that just so happens to be the fibrils and the GAGs that are present in all amyloids. Fibrils and GAGs especially, have very high numbers of negative charges on them. And these GAGs are very amyloid specific. So in amyloid, the GAGs have even more charges on them than you find on other cells and around the body. And that allows you to get specific amyloid binding. So you can imagine these positive charges bounce into these negative charges, and the peptide sticks. And so in terms of imaging, what we've done is we've made the peptide radioactive, and we use another form of iodine, radioactive iodine, that has a 4-day half-life, which allows us to take images many days post-injection if that's warranted or necessary. And this is how the imaging is actually performed. The patients actually sit in a PET scanner, which is essentially a ring of detectors. Each one of these gray boxes can detect radioactivity. The patient lies, or actually sort of moves through this ring. And whichever part of the body is in the ring, if there's radioactivity there, the radioactivity sort of flies out, actually sort of in 2 straight lines. These detectors detect it, and we build an image that way. And we can build an image from the crown, and we actually image down to the thighs, and we do some leg imaging as well by moving the patient through these detectors. And one of the benefits of this type of imaging system is that we can generate 3D images, which allow physicians and patients to get a better view of the organs that might be involved with amyloidosis, and a clearer picture, we think, than certainly the SAP images I showed you just now. So in terms of the clinical trial, how it's actually being made up, part 1, there are 3 patients with AL. They were given radioactive P5+14, and for the initial evaluation of safety, and to actually calculate the radioactivity, the radioactive dosimetry that the patients would receive following these injections. And these patients, they were absolute troopers, and they were imaged 7 times over 48 hours. And I can't thank them enough for participating in that. That part of the trial has been completed, and we're now in part 2. Part 2 involves 40 patients, and they're broken down according to how the FDA required us to represent the distribution of amyloid in the population, so at the time. So we have 20 AL patients. We can recruit 10 TTR, 5 ALEC2, and 5 other. And the other are the rare, probably hereditary forms of amyloid that we're seeking to image and recruit. To date, we've imaged 12 ALs, 4 TTRs, 2 LEC2s, and we've imaged 3 others: a localized light chain amyloid AL, an A-lyse lysozyme, and an A-gel, a gel saline patient. Each patient receives a low dose of the peptide given intravenously over about 10 minutes infusion, but we sit there and we monitor you for an hour after the infusion. And then the patient comes back at 5 hours and 24 hours post-injection to be imaged on the scanner. The study, because it's a phase 1, is assessing safety, and it's determining whether we can image individual organs that are known or suspected of containing amyloid. And the way we're doing that is we are, after informed consent, the patients allow us to access their medical records, which we go through, and we note where the physicians during the patient's workup and management have suspected amyloid: heart, liver, spleen, kidney. We note that in a log. And then one of the goals of the study is to show that we can image the organ that the clinician knows has amyloid. And we call that organ-specific sensitivity measurements. And at the end of the study, the patients get to see their images, and then they receive copies of their images. And we think that's important because it is part of your health information, and we're happy to do that as well. So as part of the protocol, the patients come to Knoxville and they visit our study physician for a checkup, and that happens on a Monday morning. And it takes about an hour, and the rest of the day is free. Also, on that day, the patient will begin taking a 7-day course of iodide pills, which is designed to block the thyroid and prevent radioactivity from entering the thyroid. And then on Tuesday morning, the lab produces the radioactive drug at the medical center. We do that between 6 a.m. and 10 a.m. And then the patient comes in, and they come into this room here about 11 a.m. and lie down. It doesn't look this neat normally. It's much more cluttered. And we're all there with the patient, and the patient will be here and will be infused over 10 minutes with the radioactive peptide. And then there's a 10-minute salt water flush. And then we monitor you for 50 minutes following that, just to make sure temperature, heart rate, everything is normal after the infusion. This is the kind of setup on the right here that we use. This is a lead-lined injector. We put the syringe in here, and that's for our benefit and safety, not for yours, because we work with radioactivity all the time, so we need to be protected. The infusion's very quick, and we've had no incidences of any issues associated with the infusion of the 24 patients we've done so far. This is the scanner. So after the infusion, the patient can leave the medical center for 3 hours, and then they come back about 4:45, and then they recline on this bed, and the bed actually moves through the scanner. This is the PET ring I showed you. This is where the radioactivity needs to be. And the imaging session takes about 50 minutes, 55 minutes, and you will move slowly. The patient moves slowly through the scanner, and we take the images. And what we do for the imaging protocol, we spend 10 minutes imaging the lower legs because we're interested in looking at neuropathy in patients. Then we'll do a whole body scan from the top of your head down to your thighs. And then we'll do a 10-minute scan over the heart as well, because we're very interested in looking at the heart. It's not an MRI scanner. There's no noise. It's not claustrophobic for 99% of the patients, but we do, we have a picture in the informed consent of what the scanner looks like. So if you are claustrophobic, you get a feel for what it might be like. So a little bit more, but I'll show you some images now. So a little bit about anatomy. This is the idealized human on the left-hand side here. You can see the heart on the left-hand side, the lungs behind the heart, the liver is below the heart, and then you have the spleen over here, the stomach wraps around here, and then you have the intestines. The kidneys are sort of hiding behind here in this orientation. This is important because it'll help you understand what you're looking at in the next images. And as I mentioned, these are 3D images that we're generating, and that allows us to do what we call sort of planar views. So it's almost, so we have a 3D picture of a human, but we can actually sort of just take a look through one slice of that image, and we can go from top to bottom, head to toe, or we can go across the patient this way and get a view of the organs sort of in that angle. And this is, we call this an axial slice, and I'll just call this another type of slice. So what type of images can we generate? So this is one of our patients. This is a whole body view with all the radioactivity there. And this is the lungs, as I mentioned, head, obviously, shoulders. This is the heart, and this is the spleen. You can see 2 kidneys, and the radioactivity here is accumulating in the heart to some degree, the spleen, the kidneys, and the liver. This is a patient, oh, and also the bone marrow. This patient also had bone marrow involvement. This is the bladder, where the peptide that's not bound to amyloid will get cleared through the kidneys, enter the bladder, and leave as urine. So this is background information. Again, what the advantage of having 3D imaging is you can actually evaluate these images in multiple ways and get the maximal type of information. This patient was actually diagnosed, he's the only one we had diagnosed where liver involvement of amyloid was the primary concern in this patient, but we also identified liver in all these other sites, which was not known in the clinical record. This is the same patient, and now we're looking at slices through the patient, again, to get maximal information. This is a slice through the liver that we've seen before. This is the GI tract. This is iodide leaving. This is normal. But this is the heart. Dr. Ruber gave a great talk about what the heart looks like in several views. And he mentioned the muscle on the left-hand side of the heart, which is the side that pumps the blood around the body. It's the thickest muscle in the heart, and it's where amyloid deposits, and you can actually see it. And you can see this is with the left ventricular wall here, and then you can see sort of atrium here and other regions. This up here is, there are glands in the head and neck, saliva glands and what we call parotid glands. They take up iodide. So this is background, we think, in most patients. So if you see this, it's not a concern from what we're looking at. And then if you take this image and you sort of like do a slice across this way, you get this type of view. And you can actually see this is the splenic amyloid here. This is the liver amyloid here. This patient actually had amyloid in his pancreas as well, which sort of spans this region here. So this is pancreatic amyloid. Another view of the heart, which is again what clinicians are really interested in. They want to see the uptake or the amyloid deposition in the left ventricular wall, which is here. And this is, I think, the right atrium. Rick will probably tell me off in the comments later. And this might be the right ventricular wall. But what's amazing to us is that the uptake of this peptide is really providing very exquisite images of the distribution of amyloid very cleanly in each organ. And you can see actually in some of these images uptake in the bone marrow in this patient too. The intensity of the reds and greens is quantitative. So white is extremely high radioactivity. So depending on the color, that tells you how much peptide is in that organ. And we also think that means it's an indication of how much amyloid is in that organ. So we can say there's a huge amount in the spleen relative to the liver, relative to the bone marrow, and relative to the myocardium. One of the things we're trying to understand is how much amyloid in the heart do you need to have significant problems associated with amyloid in the heart, how much amyloid in the spleen can be tolerated, how much in the liver before things start to go haywire. So this patient also had some renal uptake as well. It's very light, but it was positive. So I'll show you some more images with different things that we see. So this is another patient. This patient was diagnosed with lung amyloid, and that was the primary diagnosis. And you can see in the middle picture here, you can see this is the outside of the lungs. You can see some blue, which we haven't seen in many other patients. Also, there's some cardiac uptake as well, which was not known. And this is the adrenal gland, which was also positive. Again, this patient, you see this classic horseshoe in the left ventricular wall. What's remarkable about this patient, unlike the one I just showed you, the liver is absolutely negative, the spleen is absolutely negative, and the kidneys are absolutely negative. So every patient is very different, and each patient helps us learn more about the next patient. So this is this same patient, and now we're going to focus on the lungs. You can see the edge of the lungs is called the pleura. And you can see this patient sort of lined up exactly according to the diagnosis. This patient was diagnosed with lung amyloid, and we were able to detect amyloid in the pleura of this patient. Again, kidneys absolutely negative. This is another patient. Again, this is a different presentation. The heart is involved as well. We see the heart in almost all of our AL patients. The lungs in this patient lit up, but not as much. But this patient actually did have cardiac. So this patient who was diagnosed with cardiac amyloidosis, this was the known region, but there was some suspicion of lung, and we actually saw that, and there was some suspicion of renal involvement, and we actually could image that as well. This is another patient who had the most extreme amyloid deposits we've seen. This is the kind of image you might see with SAP, except for the heart. SAP can't image the heart, but you can see this massive accumulation of radioactivity in the organs, like this is the liver, the spleen's buried in here, probably there's a couple of kidneys buried in here, but you can't get any resolution. You can actually see the shadow of the heart, but the bone marrow in this patient is absolutely remarkable. And there's also some uptake in some regions around the brain. If you do the slices and you look at this patient had a lot of calcium in the liver and spleen, but where there was no calcium, there was uptake of the radiotracer. So this is the liver, this is the spleen, and this is the same patient with some more views. The heart lights up, but it's very weak with respect to the liver. This is the 3D image on the left, which should play. Again, giving you more information and a better view, I think, of the entire body as a whole. We're able to see, again, liver and spleen. This patient also had pancreatic uptake, and I'll talk a little bit about that as we get to the last patient I'm showing. And then some, as I say, a lot of calcification in the liver and spleen, and where there's calcification, there's no uptake of radiotracer, but certainly around the calcifications, there was uptake. And in this patient, we actually saw uptake in 2 regions of the brain which are known to contain amyloid in AL patients, areas that are just because they're highly vascularized. This is called the choroid plexus and the pituitary. And I show that because I don't think this has ever been imaged in AL patients before, but it's been known in the literature. This patient was also remarkable because she had had a kidney transplant before her stem cell transplant due to severe renal failure associated with amyloidosis. And one of the things she was interested in was looking at her transplanted kidney. And so I show you here her images of her right kidney, which is this area here, which has uptake in it. It's green, it's not negative. So there's amyloid in the right kidney. This is the left kidney. There's amyloid in that kidney. But when we looked at the area where the transplanted kidney was, around the pelvis area, there was absolutely no radioactivity uptake at all. So this would suggest that there's no amyloid at all in a transplanted kidney. And that correlated very well with serum biomarkers. This patient had one of the highest EGFRs of the best EGFRs of anybody that we've imaged so far. So very good renal function. And we think that's associated with a complete lack of amyloid in that transplanted kidney. This is a good example of a patient with extremely severe cardiac amyloidosis. This patient has a very large heart, enlarged heart, and as Dr. Ruberg said, there's a lot of thickening of the muscle walls. And you can see here's the left ventricle here. This is the right side of the heart, the muscle on the right side. And then you can also see the small chambers that receive the blood are actually also involved as well. This is the most dramatic heart picture we've ever seen. Also in this patient is there was a significant amount of radioactivity seen in the kidneys. And this is the same patient with this incredible uptake in the kidneys, and this is the spleen, but the liver is completely spared. And this is something that amazes us every time when we see these patients is we knew weekly image that very different with this patient, very unique. This patient also had some uptake in the back of the tongue, which we were able to see. My internet is unstable, so I hope you can still hear me. This is the last patient I'll show, and this patient is was interesting to us and still is because she had splenic amyloid and kidney uptake, but also uptake in the pancreas. And we're not sure what this means. This patient was a type 2 diabetic who was taking oral insulin, and those patients can get amyloid in the pancreas that isn't light chain amyloid or TTR. It's associated with a protein called islet amyloid polypeptide, IAPP. And so we're quite interested in whether this amyloid in the pancreas that we're actually seeing is associated with the AL, or whether it's associated with diabetes or some sort of diabetic insult. So we're going to be working on that in the future as well. So what does normal look like? And we don't have any healthy subjects enrolled in phase 1, but in one of our AL patients who was diagnosed with renal insufficiency back in 2012, had a stem cell transplant in 2013, and with, I think, 1 round of chemotherapy, had a complete hematologic remission, which was extremely stable. And she had a very low EGFR, but from the stem cell transplant, it remained stable. This is this patient. And there is, even though you can see radioactivity, this is the stomach. There's absolutely no uptake at all in, let me go back. There's no uptake at all in any of the organs. This is the heart, and this is the liver. The blue that you can see here is the blood pool. You can't see the characteristic horseshoe shape. The spleen was negative. The kidneys were negative. This patient was absolutely negative. And as a few people have mentioned today, this has been seen. If patients with sustained hematologic remission, the amyloid that they know is there can disappear, and we think this is an example of such a patient. So this is what normal looks like. Absolutely no uptake in the major organs, just the stomach. And this stomach is the free radioiodide that's sort of generated during clearance of the peptide that will just sort of pass out through the intestinal tract. One of the other things we do, I've mentioned, we've looked at lots of other types of amyloid. I just wanted to show this because it demonstrates that we can actually see cardiac amyloid in TTR patients. ALEC2 patients, we can see uptake in the organs that are known to contain amyloid, but we don't see activity in the heart. The Gelselin patient, we actually see incredible uptake in the kidneys, even though this patient had absolutely normal kidney function by any other metric. And the lysozyme patient here, this is 2 images to show extremely widespread and diverse amyloid in multiple organs and in multiple amounts. The spleen has the most, heart is involved, kidneys are involved, and also regions of the liver are involved. And this patient also had pancreatic involvement. So what have we learned? The infusion of the peptide P5+14 is very well tolerated by patients. We image at 5 hours post-injection, and that can provide excellent images with low blood pool background. As I just showed, the peptide has imaged diverse organs and multiple tissue types, including the heart, lung, liver, spleen, tongue, adrenal glands, pancreas. So we're able to see amyloid in lots of different places, and that's important because there are other imaging agents out there, including SAP, that at present can't achieve all of this information in one scan. It can be achieved with multiple tests and protocols, but not with one scan. So we're excited about that. The patient sensitivity, which is how many patients have we enrolled that we know have amyloid and actually image, and we're at 96%. The only patient we haven't imaged is that one I just showed you, who we think has clearly had amyloid when she was diagnosed, but has since, through complete remission, the amyloid has just gone away. So she's the only patient we've missed. Organ sensitivity, this is the measure of if the clinician knows you have amyloid in the heart, how many hearts did we image? And we're at more than 90% of that for all 24 patients. As I just showed you, the peptide can image at least 5 different types of amyloid, and we're working on extending that to see how broad the reactivity could be and how useful this could be. And the data we have suggests that we can image amyloid in the heart, notably, but possibly other organs before there are changes in serum biomarkers that indicate you've got amyloid in the heart clinically. And we're excited about exploring that too. So what's next? We're going to update the protocol to add more AL and TTR patients. We're going to include 10 asymptomatic TTR mutation carriers and 5 healthy subjects to get that data. We're also going to request that we perform repeat imaging at 12 months after the first image is collected. And we want to compare amyloid load from the imaging with quality of life information to try and demonstrate that how much amyloid you have and where it is impacts your quality of life, and that we can sort of monitor changes in load and hopefully show that quality of life improves. And we're also going to remove the 24-hour imaging session because we've learned a lot from using it, but not as much as we thought. So just in terms of convenience, we're going to move that. And we're preparing grants to do that. Perhaps one of the more exciting things that's coming from this study, given the fact that the peptide binds amyloid so well and many types of amyloid very specifically, is that we're now using the peptide to develop therapeutic drugs based on that will allow us to clear amyloid from organs. And you can see the peptide gets taken up by the amyloid in every organ, and we anticipate that the therapeutics will be effective at removing amyloid from those organs. The peptide is now being developed by Aurora Bio. They're helping to move this forward towards clinical evaluation and approval by the FDA. And we're planning a pivotal phase 3 study that will involve about 150 patients. And then we'll move towards trying to get this approved by the FDA so we can get it into clinics and make use of it. This is the group I work with here. This is the amyloid group in Knoxville, Tennessee. This is some of the imaging folks, but this here is the entire group of people that are required to do the imaging study. And with that, I thank you, and I look forward to any questions in the Q&A. Over to you, Muriel.
Thank you so much, Dr. Wall. Before we go to Tracy with questions, I have the enviable position of having access to you right now to ask you some questions. And something that I want to get answered from you is when this peptide is in the body, if someone has kidney involvement, they would be concerned that clearing it through the kidney or through the liver, if they have liver involvement, might compromise the liver or the kidney in some way. And I'm sure that that's not the case, or you wouldn't be talking about it. So can you tell us about that concern?
It's a concern that lots of people have. People ask us more because when you have a CT scan, they often use a contrast agent, and that can be very damaging to people with impaired renal function. So that's what people ask us. The amount of peptide that we're injecting is very, very, very small, and the amount of radioactivity we're giving is extremely small. And so we have no data to indicate that there's any acute change in function of the kidneys. And we follow the patients 28 days out, and the patients are in contact with us constantly after they've been imaged. And so we have no data to indicate that it impairs, it's damaging for the kidneys with amyloid.
Okay, thank you.